Hello, my name is Mary Beth Farrell, and today I'm going to be discussing healthcare regulations, patient safety, quality, and reducing healthcare costs. Let's start by discussing compliance with regulations. Most healthcare workers consider compliance to be nothing more than another example of government interference and the imposition of rules and regulations on people who are already overworked, underpaid, and underappreciated. And although it can be just that, healthcare compliance can also help to improve the quality of healthcare while controlling costs. Healthcare compliance is defined as the continuing process of adhering to legal, ethical, and professional standards. An organization must have systems, processes, policies, procedures, training, and monitoring in place to ensure appropriate behavior and organizational conduct. There are just too many regulations to cover in one presentation, so I'm going to give a brief overview of a few of my favorites, if it's possible to even have favorites on this subject. I'll be discussing HIPAA, the OSHA Bloodborne Pathogen Standard, fraud and abuse, and research involving human subjects. So let's start with HIPAA. The Health Insurance Portability and Accountability Act was established in 1996, and included in the act was the privacy rule, which sets standards to protect a patient's medical records and other personal health information. The rule applies to healthcare providers, health plans, data clearinghouses, and any health electronic transactions. The privacy rule requires organizations to have appropriate safeguards to protect the privacy of an individual's personal health information. HIPAA sets limits and conditions on how information can be used and how it can be disclosed without a patient's authorization. HIPAA also gives a patient rights regarding their health information, including the right to view and obtain copies of their medical records and to request corrections as necessary. The Occupational Safety and Health Administration, or OSHA, promulgated the original bloodborne pathogen standard in 1970 after heightened awareness of risks associated with occupational exposure to blood, particularly from AIDS and hepatitis. This regulation imposes safeguards to protect medical workers from hazards associated with bloodborne pathogens. In the regulation are requirements for exposure control plans, engineering and work practice controls, hepatitis B vaccinations for workers, hazard notification and training, and record keeping. The standard is directed not just at healthcare workers, but also the employers or facilities of those workers that may be exposed to potentially dangerous and infectious materials in the form of body fluids and tissues. Moving on to fraud and abuse, there are essentially 5 main federal fraud and abuse laws in healthcare. They include the False Claims Act, the Anti-Kickback Statute, the Physician Self-Referral Law, the Exclusion Act, and the Civil Monetary Penalties Law. Let me briefly explain these 5 laws. The False Claims Act is designed to protect the government from being overcharged or sold poor quality goods and services. The Act makes it illegal to submit a billing claim to Medicare and Medicaid that you are aware of or you should be aware of that is false or fraudulent. The Anti-Kickback Statute makes it a criminal offense for an individual to pay or provide remuneration to encourage or reward another individual or entity for patient referrals or other services such as drugs and supplies that are paid for by a federal health program. The Physician Self-Referral Law, frequently referred to as the Stark Laws or amendments, bans physicians from referring patients for designated health services paid by Medicare and Medicaid to a facility where they or their families have a financial interest. There are some exceptions, hence the word designated services, such as for clinical laboratories, radiology, and physical therapy. The Exclusion Statute excludes individuals or facilities from participating or getting paid by all federal healthcare programs if convicted of 4 criminal offenses. First, Medicare and Medicaid fraud. Second, patient abuse or neglect. Third, felony convictions for other healthcare fraud offenses. And 4, felony conviction for unlawful manufacture, distribution, prescription, or provision of controlled substances. And finally, the Civil Monetary Penalties Law authorizes the imposition of civil penalties for various acts of fraud and abuse involving federal health programs. The penalties can be as low as $2,000 and up to $100,000 for each violation. Let's now talk about the human subject research. After egregious publicized cases of research abuse in the 1970s, a famous report, The Ethical Principles and Guidelines for the Protection of Human Subjects of Research, or it's more commonly known as the Belmont Report, was issued. This report provides the ethical foundation for federal regulations that protect human subjects of research. In 1991, 17 federal agencies adopted a common set of regulations known as the Federal Policy for the Protection of Human Subjects, otherwise known as the Common Rule. The Common Rule defines research in human subjects. It defines research that is considered to be exempt or non-exempt research. Approval from an Investigational Review Board, or IRB, is required for all non-exempt research. The IRB ensures that risks to subjects are minimized and reasonable in light of the anticipated benefits, and that the selection of subjects is equitable. The IRB also ensures informed consent is sought. Now, moving on to regulations that protect patients and employees. I want to discuss 5 critical areas of concern related to patient safety. These areas include medication errors, healthcare-acquired infections, critical results, patient identification, and surgery or procedural safety. To begin, medication safety must be a primary area of focus in ensuring patient safety. Medications must be properly stored and secured with ordering and distribution procedures. Medications that look alike and sound alike should not be kept near each other to prevent confusion and mix-ups. Medications must be labeled with its name, dose, and expiration date, and if intended for a specific patient, the patient's name and identification number. Care must be taken to ensure that all prescription and non-prescription medications a patient is taking are documented and reviewed in the chart for interactions and adverse drug reactions. Medication allergies should be documented, and the patient should be wearing an easily recognized wristband. Next, policies and procedures must be in place and enforced to reduce the incidence of healthcare-acquired infections. There must be hand hygiene protocols with germicidal soap or alcohol-based hand sanitizers. A facility must have infection control policies and procedures that include instructions for wearing gowns, masks, and gloves, and for changing in between patients. Finally, there must be detailed and strict disinfecting procedures with appropriate germicidal solutions. The third area of concern is the reporting of critical results. All critical test results, whether from diagnostic imaging or the clinical laboratory, must be reported in a timely manner. For instance, therapeutic ranges for anticoagulation levels from Coumadin or for drug levels such as digoxin must be closely monitored with alerts when values are outside of the therapeutic range or when blood levels reach toxicity. There must be dedicated procedures with zero tolerance for noncompliance for identifying patients. Patient wristbands must be checked prior to any treatment. In addition, 2 patient identifiers should be used, such as the patient's name, including the first and last name, along with the birth date or medical record number. This information should be verified against the wristband. And finally, there should be safety procedures for all surgeries and invasive procedures, such as ensuring informed consent is obtained and documented. A history and physical must be performed to clear the patient for surgery, along with a pre-anesthesia evaluation. Patient vitals must be continuously monitored during surgery, and there must be procedures for instrument and sponge counts. Finally, there must be strict adherence to policies for identifying the patient, surgical site marking, and timeouts to ensure that the right patient, the right site, and the right procedure. And finally, I'd like to discuss how improving quality can help to reduce healthcare costs. There's considerable evidence that Americans do not get the care they need, have worse health outcomes, and spend more per capita than many other industrialized countries. Historically, physicians and hospitals were incentivized to provide care in the form of diagnostic tests, procedures, and office visits. The more services provided, the more money to be made. However, with passage of the Affordable Care Act, payment incentives are changing. Physicians and hospitals are paid based on the quality and efficiency of care as opposed to quantity. This change in payment model is called value-based purchasing. One effort to improve quality is coordination of care, where primary care physicians coordinate and collaborate with other healthcare providers such as nurses, physical therapists, and dietitians in an effort to reduce redundant care and to make sure that patients get the care they need and that they get that care sooner. Coordination of care is helpful in avoiding hospital readmissions. 1 in 5 elderly patients discharged from hospitals in the United States is readmitted within 30 days at a cost of over $17 billion. Many readmissions could be avoided through increased communication between hospitals, physicians, and the community or home health care programs. Similarly, there is evidence that chronic care management programs have significant impact on the elderly and those with chronic diseases in the form of improved outcomes, increased patient and family satisfaction, and reduced costs. Another quality effort to reduce costs is through increased safety, such as by avoiding mistakes that result in patients acquiring infections in the hospital or suffering adverse events and other medical complications that I spoke about in the last section. In summary, there is evidence to prove that improving quality can reduce costs. For instance, Medicare linked hospital payments to readmission rates. As a result, the rate of hospital readmissions dropped by 10% in 2013 compared to previous years. This is estimated to have avoided 150,000 readmissions in 2012 and 2013. There's been an estimated 17% decline in hospital-acquired conditions between 2010 and 2013, with 1.3 million infections, accidents, and other adverse events prevented. This alone is estimated to have saved 50,000 lives and saved $12 billion from not treating those types of conditions. And probably the most important indicator that quality and safety improvements are having an effect is that the rate of growth of healthcare spending has slowed. Data from 2011, 12, and 13 demonstrate that the slowest growth in real per capita healthcare spending since the 1960s. These results are all encouraging, and with increased focus on patient safety and quality, along with value-based payment models, there is reason to believe that the U.S. healthcare system can be upgraded from a critical condition to stable in the next few years. Thank you for listening.